What I'm going to talk about today is a very small piece of the Canadian healthcare system, and to some extent this is a report on what I did during my sabbatical, which I spent at the University of British Columbia in Vancouver, which has probably the best, at least according to them, the most expert group of people who follow, monitor, and have inputs to policy in healthcare in Canada. So I felt very privileged to be able to spend my 6 months with them and enjoy the city of Vancouver, where it rained nonstop between the day I got there and January 30th. Title of my talk, Management Challenges in a Public Healthcare System, the Case of British Columbia. I focused on management in part because that's what I teach in our Health Services Administration program here at the Price School, but also because I got the impression that most people who have studied Canada, and there are many such investigators, really don't do so from the ground up. It's more of a macro policy approach that tends to get taken. And from my own perspective, a system doesn't work very well unless you know how it's managed. And no policy can really be carried out very well unless it's feasibly managed by capable individuals. And that's the perspective that I went about my work in pursuit of. Now, I thought I'd start out with a map of Canada because probably there are at least some people here who don't know what it looks like, and this is what it looks like. And the province I was in was British Columbia, which is the westernmost province. Yukon is not a province; it's still a territory. And to take another look, a closer look at British Columbia, it turns out that the system is managed and delivered by a network of what are known as health authorities, or as I refer to in the paper that accompanied this talk, regional health authorities. And each of those has a geographical jurisdiction in which they deliver services. They run the hospitals. They also have a public health function. They run long-term care facilities, various other facilities for mental health and special populations. And so there are 5 that manage geographical regions in British Columbia. There is one additional one known as Provincial Health Service, which is constituted as a regional health authority, but covers the entire province for some specialized care such as pediatrics and cancer treatment. Now, the place where I did most of my work was in the Vancouver area, and I think there are about 3.5 million people living in the Vancouver in British Columbia, and the vast majority of them live right down here, within 50 miles of the U.S. border. And as you can see, there are 5 authorities where most of the population lives, and that's where I did most of my work. I never got up to Prince George in northern British Columbia for 2 reasons. One, that the roads were bad, and it was said you couldn't drive there until summer. It was too expensive to fly. But the major reason being that my major contact in the Northern Health Authority was somehow disappeared as a result of a cryptic scandal that I never really got to the bottom of. Nobody really wanted to share the information with me, so I hopefully will get back there someday if things ever stabilize.
In terms of the sort of provincial setup, do all of the provinces have this sort of regional, and then there's sort of a provincial provider of the sort of specialized services? Is this kind of typical for Canada?
Well, I'd say it is typical to the degree that anything is typical. And the reason why I give you that answer is that the way the Canadian Constitution works, the provinces have a lot more power and a lot more responsibility for delivery and management of healthcare than our states do. So it's much more a province by province arrangement. You know, people say, well, Canada has a single payer system, but they don't. They have 13 different single payer systems, but they're all jurisdictions of different. They differ in terms of jurisdictions. So you're asking a complicated but a really interesting question. I'd say the pattern holds for most of Canada, with 2 or 3 exceptions that I can think of. One of them would be Alberta, the very next province over going east, and the reason why Alberta doesn't have regional jurisdiction the way British Columbia does is that there was a political dispute, excuse me, between the premier of Alberta and the management of two of the health authorities. So he dissolved the health authorities, and now there's a single health authority. It's basically a state agency under much more direct jurisdiction of the provincial government. So a lot of politics, and same thing. And you could say in Halifax, excuse me, in Nova Scotia, where you have a relatively small number. Compared with the number you have here, maybe they've got 3 or 4, and here you have 5 or 6, relative to the population. Again, you can, depending on who you listen to and who you talk to and what you read, you could argue that there is a political agenda associated with the configuration and size of the health authorities. In, let's see, Prince Edward Island, which is tiny but is a province, you only have 1 because the population is so small. The real puzzle for me, I hope to learn more about this in the years to come, is in Ottawa, which has about half of Canada's population. Excuse me, not Ottawa, Ontario. And Ontario does not have formal health authorities the way the rest of Canada, most of the rest of Canada does. It has clusters, which are known as networks, with different organizational and jurisdictional features to them. So that's a long, complicated answer to a very simple question. But you see, for an organizational sociologist like myself, this is about the best playground you could ever find. Now, I have to say, when I arrived in British Columbia in January, I had never heard of a health authority. And basically, I sat down with the faculty at UBC and various individuals they identified as good initial key informants, a couple of them who were ex-CEOs of these agencies, and I found out the basics of the health authorities. And so fundamentally, most of my time up there was really focused on specifically the health authorities and regional health authorities, and specifically on hospitals. The reason why I focused on hospitals is that it's easiest, they're the easiest organizations to really understand. They're formal organizations, they have specific places they operate, and they also soak up a tremendous proportion of the healthcare funds of any modern system. So a lot of other things go on that I don't really know enough about, such as the organization of medicine, such as the organization of nursing, such as mental health and general public health, and preventive measures outside of the jurisdiction of the health authorities. So there's a lot I don't know, but with that disclaimer, I did focus on the relationships between the hospitals and the health authorities. Now this is a quick overview of the size of the health authorities. These are the 5 that have specific geographical jurisdictions, and you can see they range from one that serves a population of 1.6 million, the largest one, the largest 2, known as Vancouver Coastal Health Authority, and Fraser Health Authority, named after the Fraser River, which runs through its jurisdiction. So you have some very large ones with fairly large budgets, well into the billions, and then Northern, the one I never got to, is they only serve a population of 300,000. Very few people really live up there. The distribution of the population in that part of British Columbia is very sparse.
It's just interesting to note the kind of implicit per capita budget, right, which seems to vary.
Yes, and I wish I had put that in the table, because it really would be an interesting object of conversation. Another dimension of this is that all of these different authorities have different challenges. So, for example, Fraser has a very large immigrant population. A lot of the new development in the Vancouver metropolitan area is taking place in their jurisdiction. The Vancouver Coastal Authority runs the system for central Vancouver with all the problems you'd expect of a large city. You go out to the northern area, they're flying around the little planes, they're flying doctors into these little settlements that are no more than mining camps a lot of the time. My favorite place, if I was ever going to live there, would be the island, Vancouver Island, which is interesting in that it's the southern part is the administrative capital of the province. The northern part is very rural. As a young guy, I used to hitchhike around there, so it was nice to go back. So, you know, in terms of each of these different places, let's see. Interior health, that was an interesting one too. I mean, they have the issue of whether they should develop their own tertiary care facilities or try to work out an effective and efficient and prompt system of transferring patients to the cities. So I mean, they all have separate challenges, and it's kind of interesting to see how they deal with them. Here's some pictures. This for better or for worse is where the Fraser Health Authority has its offices. One of my favorite buildings in the Vancouver area, and Simon Fraser University is also located there. And you can see the light rail, which is very nice because it takes you an hour and a half to drive from central Vancouver, but it only takes about 30 minutes on the train. Wish we had something like that. Okay. This is one of the hospitals, which I like. It's got nice architecture, although it's thoroughly obsolete. And they've been waiting for about 20 years to get a thorough renovation, which raises some of the issues regarding capital formation in the system. But they just, I think, have approved it, so they will go ahead with a major renovation. It's one of the old facilities operated by the Sisters of Providence. Here's Vancouver General. I spent a lot of time here as well. And this is the flagship of the system in British Columbia. It's the big tertiary care facility. It's got a lot of different buildings. You really have to respect the people who work there. As I said, it was a venue for an awful lot of my research. Now, why do I show this one, the signage out in front of the Vancouver General? I use this in my marketing class. I teach a healthcare marketing class, and I say, you know, people always give me a hard time in Canada about being someone who believes in marketing. It's a capitalist plot. But this, in my opinion, is not good marketing. I mean, I keep saying, look, you know, we go there week after week, and nobody ever fixed it. Nobody ever put another board down there so it wouldn't be an open-air garbage can. And that's not a good marquee for a facility of any kind. I used to say, well, I'm not much of a carpenter, but if I ran that facility, I'd be back over the weekend with a board and a can of paint, so at least nobody would notice it. Well, the research questions that I have, and I don't know if you folks have had a chance to read the paper. If you're especially interested, let me know, because I'd appreciate any feedback you can provide. The research questions, again, as I said, I'm focusing on acute care that takes place in hospitals. There are a lot of other things that one could argue are much more important in health and health care, but with that disclaimer, first one is just an empirical question. What kind of management problems arise in the British Columbia healthcare system? And you know, it's a curiosity question. As I said, the ideology this drives the research is that a system doesn't work well, no matter what policy is behind it or how well it's conceived, unless it can be and is administered effectively. So what are the challenges? Second, what solutions? Again, an empirical question. And then some less empirical questions, more questions which are broadly applicable to a lot of different systems, is do management challenges obstruct policy objectives? Now, if we say the policy objectives fundamentally are appropriate care, appropriate and prompt care, access, if you will, for the consumer, and restraint of costs, which is driving everybody mad throughout the world regarding healthcare. Second, does the management strategy maintain the system at the expense of public service? Now, this is really an equilibrium question. You can theorize that any kind of administrative system really works well because it maintains the system. If you've ever read the work of Philip Selznick, that's some very early thinking in that area. But the question really is the public well served, or somehow or other does the system serve itself along with the public, but could they do a better job if, in fact, you didn't have the prevailing equilibrium that's developed through management practice? And the last question should be of interest to everyone. What are the implications for the United States as the Affordable Care Act is implemented? Because there's some parallels between the system in British Columbia and what I think we're going towards with the Affordable Care Act. And that's, of course, something all of us need to be thinking about. If I need to speed up, let me know. Okay. Methods I used were basically the process of an interpretive case study, where I put together information from a lot of different sources. I did a lot of interviewing, mostly snowball sampling. Who can I talk to next? And I went out and pursued people. I interviewed 30 people, usually between an hour and 2 hours. I can't believe how generous people were with their time. It's a real pleasure. Review of documents. I spent a lot of time reading legislation, which is an interesting thing to do. What are the actual obligations that these agencies have? What are the jurisdictions? Who rules? Who can dissolve the agency, etc. Organizational charts, lots of government reports. One thing that you find a lot of in British Columbia and probably throughout Canada is a tremendous number of royal commissions that periodically re-examine the healthcare system and come up with recommendations, which then tend to be implemented. So it's important to know what they are and important to review them. Observation of board meetings. I am a sociologist, so I like to go to these things, and they're very interesting to see what gets argued about, who shows up, what they say. Then talk to the CEO or the head of the board and ask him what he or she wanted to accomplish and whether that happened. So I had a lot of good opportunities to do that. And then, I read the newspapers and I watched TV. Very useful. And talked to a lot of Canadians I would just meet while I was there. All walks of life. So what are the features of the system? Number one, global budgeting. Now, how does that work? Well, the federal government generates about 20% of the, well, now it's probably closer to 25% of the funds that each province allocates. The rest of the money has to be raised by the provinces in the form of taxes. And the mechanism by which money is transferred from the federal to the provincial governments is known as transfer payments. They occur in health, but also some other areas. Service delivery is managed by 5 regional and one provincial authority. Those are the ones I just illustrated. So they operate the hospitals. They employ the administrators. They employ the nurses. They do not employ the doctors. That's another story. They employ the nurses and other healthcare workers, and they are the official employers of the executives and support personnel at the regional health authorities themselves. Now, who owns the hospitals? This wasn't a simple question. I had to dig for that one. I kept asking my key informants who own the hospitals, and nobody had a good solution. You can imagine people have actually managed these systems, and I'd ask them who owns the hospitals. Well, I don't really know. So what I did is I started talking to lawyers, and I interviewed a number of lawyers in the Vancouver area who are specialists in healthcare. And again, they haven't sent me a bill. I feel very fortunate. So I ended up drawing the conclusion that basically the provincial government owns the hospitals. And the reason why, you can argue it 2 ways. The hospitals can be thought of as owned by the regional health authorities, because when they get sued, the health authority gets sued. And so the health authority will be sued as, let's say, the Fraser Health Authority, doing business as Vancouver General Hospital, for example. So they would sue the health authority, and that's a pretty good indicator of ownership. The other dimension, though, is that the insurance against which the suits are recovered is purchased and arranged by the provincial government. So anyway, figure it out. Figure it out. There's the 2 clues that I got.
So this is what happens when you have socialism. Well, nobody knows who owns anything. It's just a mess.
Well, no. I mean, the state owns everything.
Well, which state?
Well, in this case, it's the province. I mean, if I had to argue who really owns it in a substantive fashion of ownership, I would say it's the province. Got it. And I'll get to that in a little bit. Okay, so devolution of, I'm sorry?
The authorities wouldn't have any authority except by virtue of the state.
Well, the public expectation is that they do, but if you read the legislation and you watch what goes on, ultimately the agency that is the final decider is going to be the government. Now, I've got to rush the case and say, when I say government, I'm using it in the Commonwealth phraseology. And we have a Commonwealth person here, so he can correct me if I'm wrong. And they say the government. The government means the elected officials who are in charge. So, for example, we used to joke in college a lot that the British would say, "Oh, we want to bring down the government." That meant they want a new election and replace the party in power. And we said it in the United States. It meant we want a revolution that destroys the institutions. So I'm using it in the Commonwealth phraseology. So when they say the government, they also don't mean the administrative structure and they don't mean the institutional structure. They mean the ruling party, presumably the cabinet. The closest synonym I can think of is the cabinet represents the government. So when I use the word government here in the paper, that's what I'm getting at. Okay, so the government owns it, basically. They can dissolve the board. They can fire the CEO. They can replace those individuals at will with what is known as a public administrator. So imagine if let's say the Scripps Institution we're in this position where the governor of California could say, okay, Chris Van Gorder, I'm going to replace you with a public administrator, Lisa, for example. He would have the power to do that. Okay, devolution of funding. Basically, every year, each of the province figures out what its budget is going to be for health, which now is about something like 45% of the provincial budget of British Columbia, a lot. And they devolve it. They hand it out to each of the authorities. And there's a process by which this takes place, which I'll go into a little bit later. But basically, you're given a sum of money. Okay, Vancouver Coastal Health, here is your $2 billion, and you have to live with this for the coming year. And then the authority has the autonomy in allocating specific funds to each of the hospitals and other institutions that function under its jurisdiction. And that's the mechanism, that's the outline of how the global budgeting dimension works. Okay, so government authorities, governance of authorities by local boards, but accountable to the Ministry of Health. Now, again, this is something a lot of people don't have a very good understanding of, either in Canada or the United States, that according to the legislation that set up the local boards, the health authorities, the local boards that they have, which are appointed by the provincial government, by the way, have authority over the board, but actually they don't, because they can be removed. The question I would ask is, how did they get appointed in the first place, and how does one get appointed to any kind of government board or board of a nonprofit organization? Similar process here. But again, the peculiarity is that the board can fire the CEO, but the province can replace the board. Or the province can replace the CEO, but keep the board. Again, it gets very complicated if you really look at the details. That's what I spent my sabbatical doing. Okay, reading up over legislation in the local pub. Okay, amidst the hockey games. Government authority by local boards, but accountable to the Ministry of Health. See, part of the ideology behind it is that the local people are supposed to maintain, are supposed to have authority over the local boards. And in some provinces, they actually had a system where there were elections for board members. But that's gone the way of, that's on the scrap heap of history, in part because people didn't vote. Maybe 10% of the population would vote in those elections, so it didn't seem to be working, and it's not operative, to my knowledge, anywhere in Canada today.
I can ask these boards, they really seem to be just accountable for execution of a more centralized strategy.
I think you could say that. It's a reasonable thing to say. You want to say any more about that right now?
It just feels weird. Like, it feels weird that you're there and you're being judged on the execution of something that maybe you had no agreement with.
Well, well, actually, yes and no. The answer to that question is really yes and no, because the objectives of a board and the funding they get for any of an RHA in a particular year is negotiated through an annual process. So the business, there are two items that there's an annual budget and there's a three-year rolling business plan. And those are produced, those are written by the agencies and under the authority of both the CEO and the chairperson of the board. So formally, yes. I mean, excuse me, formally, no. Formally, they have the ability to set their directions. But again, you know, the money comes from the province, and the province has the legal authority to dissolve the board and fire the CEO. So again, you know, as I said, this took me months to figure out, and most people don't know it. You have to really read the legislation and cogitate. Okay, by the way, as a speaker, I had one of the former CEOs, two of the former CEOs of the agencies read the paper, so it's correct, at least as far as the three of us know. Yes?
So I was wondering, I mean, if nobody really knows who, I mean, it seems like there aren't super issues arising practically from this, because if the Ministry of Health was having problems, or if the provincial government was having problems or something, then presumably some board members would be fired or CEOs would be replaced and stuff like this. So it seems like it's working to the extent that they don't need to figure out who owns them or who kind of has the ultimate authority.
Well, they do in some respects. They do when a hospital is closed, for example, and there are a goodly number of hospitals that have closed. So the question comes up in that context. The question that comes up in that context is who owns the assets of the hospital. So if they were to somehow close that big Catholic hospital, which is owned by the Catholic Church, the land in central Vancouver is very expensive. I mean, the land alone is worth billions. So the question at that point comes up: who owns those saleable assets? So it would come up under those conditions. To the degree to which it has, I would say, has been infrequent, though. But if you hold on to that question, I'd like to address it a little bit more thoroughly if we have time later on. In any case, the last thing I'd like to point out is that physicians are independent. And it's curious, I keep hearing from people, oh, with the ACA, no one's going to want to be a doctor. It's the most ridiculous thing I've ever heard in my life. Vancouver physicians make more than physicians here, and the Canadian dollar is worth more. So you can make $1 million a year as an ophthalmologist. My guess is that it's hard to make more than $300,000 as an ophthalmologist here. And they're very privileged. They function independently. There's nothing that we would consider managed care, which is such a big deal in the United States. The fees are negotiated by a separate agency, a separate provincial agency, and the HRIs do not have any power over how much they're going to get paid or what the fee schedules are. A little bit on history and climate. There's a provincial responsibility for health that's constitutional, goes back to the middle of the 19th century. Lots of commissions and reports. Hospital consolidation, which I'll say more about in a minute. Healthcare legislation, two major pieces are the Canada Healthcare Act, which I'll say a little bit more about. Also, British Columbia Health Authorities Act is simply the act that set up the jurisdiction and the functioning and created the mandate for these agencies in British Columbia. There's similar legislation in most other Canadian provinces. Also, a great deal of pride and concern regarding the system. This is an interesting thing for me to observe. Very few Canadians complained about having a public system. They really liked it. And one reason they liked it, people kept telling me, is it makes us different from the United States. They really like to say, here's something we are doing a lot better than that giant, and that kind of sloppy giant in the South. And they're very proud of it. And very few Canadians actually do go to the United States for health care, even though they can. And they're also very concerned. I saw one poll that said that reported that 37% of those polled said that health care and hospitals were the biggest issue in their communities. The figure for the United States is 7%, which tells you why people don't like Obamacare but elected Obama. Opposing politics. This is important because you have to deal with it, and the government is the government, but the government doesn't stay in place forever. And the liberals are the conservatives. Liberals are the Republicans of British Columbia. And the new Democrats are like the Democrats of California. And they have different approaches to health care, which are meaningful. Let me know if I need to speed up. Okay. All right. Okay, so now if this were true Chicago debate, I'd still be on page 1. Okay, sketch. I've been married for 20 years, I'm used to it. Okay, all right, sketch of the system, growth and development, just a little bit of the history. You had the beginnings of public health insurance based upon hospital care back as early as 1940s in Saskatchewan, which got adopted through most of Canada by the end of the 1950s. This was expanded to be more comprehensive, to cover all medical services. And that process was completed when the last Canadian province instituted a public health insurance system. I think in 1972 is the latest one. Now, one thing to think about of importance there, crucial importance, is that in the beginning, in the 1970s, the federal government subvened the provinces at 50%. So they instituted their comprehensive healthcare systems, And throughout the 1970s and into the 1980s, the federal government paid 50% of it. Does anybody know what percentage Medicaid gets in California from the feds? I think about 30%. Does that sound about right? So Canada Health Care Act was really the culmination of this process in 1984, which among other things forbade balanced billing. So a doctor can't say, all right, I'm only getting $100 from the province, but I want to charge $150, so here's a bill for $50. I can't do it. Also, I have to say, other legislation throughout most of Canada makes private health insurance almost unobtainable. It's very, very rarely purchased or used. Now, what happened after the 1970s was retrenchment. And why did that happen? Well, here's one interesting event. There was an oil bust in the 1980s. I don't know if anybody remembers that. I remember it quite well. There's a collapse in the oil market. It went down to $8 a barrel. Price of oil today is what, about 110? So I mean, it was a catastrophe, and Canada is very heavily resource dependent. The Canadian economy is much more dependent on extractive industries than we are. So the IMF also started putting pressure on them. We're going to the agencies downgraded their debt, and it really sent a cannon shot across Parliament that they would have to control costs, and healthcare was a very big one. So what they did was they cut the subvention to 20% to the provinces, basically sticking the provinces with a huge amount of cost increase, which then they had to handle. What that led to in the 1980s and into the 90s was a closing of large numbers of hospitals. Closing and consolidation of large numbers of hospitals. So 30% of the hospital beds that were operating in British Columbia closed, or were made into other facilities, such as ambulatory care outlets. Throughout the rest of Canada, the figure tended to be higher, closer to 40 or 50% in Saskatchewan and Manitoba, for example. Current regional health authority structure probably dates from about 2000. British Columbia, I think maybe 2001, other provinces just around that date. Again, I'm really trying to figure this out and find some of the old timers who were in Parliament or in these agencies at the time to really find out the specific conversations that went on around the relationship between closing hospitals and saving money. I really need to pin that feature down, but it seems that that's what happened. Some current developments going on, which I think I'm just going to mention that it's a dynamic system. There are steps being taken to try to make the hospitals more responsive, to reduce waiting times, et cetera. And that's really for another talk. There's a lot of great research going on efficacy of these initiatives. Policy objectives, let's get back to that. Again, we're talking about the Canada Health Care Act, which formalized the things that were going on in all the provinces during those years. Something called the First Minister's Accord. They periodically try to update the system, and it's a very, very widely and conscientiously carried on policy debate. The most implicit thing, the most important thing, the big monster in this whole picture is the commitment of the government, both federal and provincial, to keep the increase in healthcare costs identical with the percentage increase in per capita GDP. That's a stated policy by at least the current Liberal government. By the way, somewhere or other, I've seen that stated by our government as well, and that's why it becomes relevant. System stressors and management. Now, in terms of what I see going on, which creates the issues for management, are what I've called system stressors, and I wish I could think of a better word, so if anybody has one, let me know. Marxists like to use the word contradictions, so I didn't use that. Or there's some other words out there. I mean, there must be something better in organization theory, and I should know it other than system stressors. But basically what I mean here is things that create challenges for managers. So there's incompatible elements of policy. One of them is access, the other is cost. You know, more access, less cost more, just that's the way it is. Conflicting interests of organizations and professions. The hospitals vie for resources with long-term care facilities, et cetera. You're always going to have that. Remember, the jurisdictions of the authorities covers not just hospitals, but many other different kinds of institutions. Individual role behavior. That's a sociological term for talking about how the executives and personnel in the system have to address different individuals in their jobs and in their social roles. And there's what I like to focus on and do in the paper is the historical, structural, and political context. So these are the stressors, basically. And I have a table. That last one is just a graphic illustrating the stressors. Here's the way I see it working. So if you look at political salience, and remember 37% of the population thinks that healthcare is the most important issue facing the community. Well, the challenge is managing relationships with elected officials and members of the boards. So if you're an official, if you're an executive, if you're a management person, this is what you have to do. It's very political, and it's got to work politically, or it doesn't work. Government fiscal restraint. Well, you know, that's something we should be familiar with. They have to meet the public's needs, and there are metrics that they have to that they're required by law to maintain. But if they do so under fiscal restraint, then that becomes a stressor. Fixed prospective budgets, they've got to balance the budgets, maintain the metrics, and let's say I don't cover this anywhere else, but by statute, the HSAs are required to balance their budgets. They cannot have a deficit. So they're handed the money through global budgeting, and they have to keep with it. They can't borrow money. They can try to get supplementary allocations, but they're very, very difficult to get, especially under the liberal government in any case. Fixed prospective budgets, okay, capital allocation. This is a whole other kettle of fish. I spent a lot of time in Victoria trying to figure that one out. So basically, there's a lot of competition for capital and very little capital out there. And it's partially a technocratic process and partially a political process. And it's not unusual to wait 10 or 15 years for an improvement that would happen here in 6 months. Yes?
Does philanthropy have a role in that?
Yes, it does. And the way philanthropy works is that if you are a clever, smart, and well-connected HSA, that was our planning agency here at one time, regional health authority executive, you can generate charitable funds, which will then work as seed money. So let's say you know, a rich entrepreneur in Vancouver generates some money for you. You can go to the provincial government and say, look, we just got a pledge of $50 million to create a new you know, a new wing of this hospital. Now, are you going to meet us halfway? At the same time, the influential person is knocking on the same door and say, I just gave $50 million. Now, how about it? I mean, I'm burlesquing it a bit, but you know, that works for a lot of things. And I can think of some instances, so thank you for pointing that out.
Can they say, I have all I need via products?
No, I've never heard anybody say that. It's a good question. Does anything get built purely in charitable funds? I never heard of it, but it could happen. In any case, that's the way I've seen it work. All right, capital allocation, independent actors. As I said, you know, we've got very powerful unions who don't negotiate directly with the health systems, with the authorities. They negotiate with the province. Same thing with doctors. And the last thing is political flux. Well, political flux is important anywhere. So by political flux, the most important thing going on, I would say, is privatization. And under the liberals, remember, the liberals are conservatives. Under the liberals, the health policy has tried to develop new facilities based upon public-private partnerships, where a private investor will build something on behalf of the regional health authority, and for the next 20 years manage it, and they'll be paid a concession fee to do that. And after that, it's cheats to the public sector, but very profitable and very controversial for the in Canada. So that's something that the Liberals like, but if the NDP takes over, there's going to be an election probably in about 6 months, then that whole process could be reversed. And for a manager, your whole playing field changes when that process reverses.
Can I ask a silly question?
Yes.
Does the manager like change? Is it like a political appointee like here in the US where if there's a change in government, your whole tenure might disappear?
Well, you serve at basically you serve at the pleasure of the province. And again, that's an interesting question. I know the board membership can, because the board members have fixed terms. The executives of the agencies do not, and they serve at the pleasure of the government. So sure, they can be removed, but you know, In terms of what went on, at least in the city of Vancouver over the last 10 years, I know 2 people who left that post.
Relating back to Australia, where the civil service that kind of does what URHA is doing, they're kind of like career bureaucrats, and they won't. It would be a scandal if they were forced out for political reasons if there's a change. So
well, you know, I would say that career bureaucrat is not an inapplicable word, but as I said, you know, people. The people that I knew in Vancouver, only 2 who had been or were CEOs in the Vancouver area were Lower Mainland anyway. Those two jurisdictions, they were the only 2 I knew who had, out of maybe 10 province-wide over a period of about 10 years, who had been forcibly removed. So they don't tend to turn over much, but they can be ejected, and they are. And the 2 people I knew best were ex-CEOs. See, they're the most readily interviewable. They like to talk about how things were and why things happened. The rest keep their mouth shut. You know, I think there's also something in the statute that you cannot make public comments if you're a CEO of an HRA, of a regional health authority. I have to check that out, but someone told me that. Okay, how are these challenges addressed? Okay, I'll take another 5 minutes. Does that work? All right. What do they do? Well, one of the major functions of an executive, whether it's the CEO or somebody else, is to diffuse controversial issues. A phrase I kept hearing while I was interviewing was, keep it out of the papers. The government does not want it. Remember, government means the cabinet and the elected officials. They just don't want controversy. They don't want people to get excited about healthcare because, you know, it puts them at risk for the next election. So one of your basic ways of dealing with it is just somehow manage it. Don't let it become a vocal public issue. That's one of the major things that people do. Accommodate interests of elected officials. You know, if an elected official wants a hospital built somewhere, a wing advanced, they love getting their pictures taken. You know, they love being it. Yes, exactly. Cutting.
Ribbons?
Yeah, ribbons. Thank you. I just left that one out. You know, they love ribbon cuttings. Okay, so, you know, if you are managing one of these systems, you've got to make that resource of public exposure and favorable news available to the government. Reconcile consumer and staff interests. This is an interesting one. The staff might want to have work rules that are not particularly favorable to good scheduling or public convenience, and that's your job as well. And being responsive to the health authority boards. Well, the health authority boards may have no real formal power, but they demand things all the time. You know, privileges, favors for people who need accelerated access, etc., and they get them. So that's the political dimension of the job. That is how, if you think of the political dimension of the stressor system, this is what managers do in order to maintain the system, keep the services being delivered, and keep their jobs. Managing under fiscal restraint, regionalization of service delivery, we already talked about that. Chase effectively diminishing budgets. And this is what people kept telling me. You know, they say our budgets are being reduced every year on a per capita basis. Now, how do we maintain public service in that kind of environment? And that's really, again, how do they do it? Well, the way they do it is, for one thing, very tight fiscal management of facilities. So, you know, people, I interviewed people from the bottom to the top, first line managers all the way up to the CEOs. And people would tell me they trade off, the agency at the top will trade off, let's say, acute care, that is hospital service, for public health needs. They'll balance negatively and positively performing both units within a jurisdiction and across jurisdictions. They make across-the-board reductions. Okay, so we've got a shortfall. We've got a budget variance of 80%, negative budget variance of 80%. Okay, we're going to cut 20% from everybody's budget for all the units of this facility. They do that across the board. That's the easiest thing to do politically. Got to fire some people. I'm sorry. Disinvest in specific services or units. This is a very interesting thing going on in Canada. I'm sure there's a lot going on in the United States as well, where there's some really smart people. A guy I did some work with named Craig Mitton at UBC, who has put together a really great system for trying to figure out consensus decisions about what to disinvest in. Now, you can disinvest in things. So, for example, Vancouver Coastal Health disinvested in a housing program they have. or there's been disinvestment in a facility for transsexual people in Vancouver, tremendously politically controversial. But you can come up with a consensus based upon fact, something like a Delphi process, and it's a very good way to diffuse potential conflict when you have to do this. Okay, they can reduce or delay best practices. Best practices is something we like to talk about in healthcare. Allegedly, the way to save money, but it can also cost you more money. Best process, and there's some illustrations in the paper about that. Regionalized services. One thing they're doing is trying to consolidate services across the province or across the province of where like 2 or 3 health resource agencies, regional health agencies will contract with a third party to do things like payroll for all 3 agencies, or they will regionalize imaging at Vancouver General, which will cover people in all the local health resources agencies, etc. Find department level economies. That's looking through the that's on the first responder level. That's on the first line management level, where the need to reduce expenditures devolves down to the first line individual who manages the local nursing staff for let's say kidney services, and she's got to look through the waste baskets for paper clips, if I may use that analogy. I don't know if they go that far, but it sounds that way. Obtaining capital, I don't really want to go into that except to say that if you've read Henry Aaron, if you've been following health policy over the decades, one thing that you hear about is upstream control over delivery of services. In other words, if we didn't have 50 CT scanners within 5 miles of here, we wouldn't get as much CT scanning. So the way to choke that off, way to control that, is to somehow centrally administer a system where you have fewer facilities. And that's part of the public policy that drives capital allocation. Again, something that people in the United States have been talking about for 20 years, but they actually do it on a large-scale, regular basis in British Columbia. Propose popular projects. You can manipulate the system, you can game the system by figuring out, when you make a proposal, the regional health systems have to submit what amount to competitive proposals for capital allocations, and you can game that by making it look good for the province, making it look good for the government. Again, I talk about that in the paper. Activating political networks. That's similar to what we were just talking about with the charitable donations. Well, I'm going to skip to some of the last things that I wanted to talk about, the questions that I begin the paper with, which I have to admit, thinking this over, I asked the questions and then realized that the study doesn't support an answer. But what it does do, which I think is equally important, is to raise the issue and frame it for future consideration, at least in terms of how our system is likely to develop as the ACA goes into operation. So, for example, the question I ask her is do management challenges obstruct policy objectives? In other words, do we have a system which is unmanageable? We have contradictory policy objectives associated with first access and second cost. That's just you're going to pay more if you generate more access. And the question, I end up with a yes or no. Yes, they reflect an imperfectly integrated system. Well, all right, no human system is perfect, and they do as good a job as you could, and these people are clever and they come up with good solutions. Second, no, they reflect incompatible policy expectations. At a certain point, you can't push the string. So again, I raise the issue but don't resolve it. I don't know if anybody can at this point. I certainly haven't. Next question I raise is, does the system serve the public as well as possible? Now, this is something that critics of the system in British Columbia, both from the right and the left, will argue. They'll say, well, the system gets maintained. Managers are smart enough and capable enough, and the system gives them enough latitude to enable them to develop a kind of a political equilibrium where the doctors are reasonably happy, the patients, the public complains but isn't disenchanted by the system. The managers of the system keep their jobs, and most people get the health care they need within a reasonable amount of time. You can argue that, yes, no system is optimal, sure, but could it work a lot better given the resources they have? And knowledgeable critics, people I respect, say no, because the unions have a lot of power. The work rules are uneconomical. Some people are overpaid. Physicians definitely make a huge amount of money. They've done very, very well under Canadian Medicare. Most people don't realize that. So the question is no. this is you know, both a libertarian and a left-wing critique that with the money we have, we could do a much better job if we weren't subservient to these elites that run and benefit the system. And the last question I have, again, focusing on the Affordable Care Act, which is really where we should be paying our attention in health policy. What are the implications? Well, the implications, first of all, take off from the point that healthcare really is, in the United States, is going to become a lot more like Canadian, at least in terms of the financial side. Because with the expansion of Medicaid that is going to occur, you will, in very short order, under the ACA, we are going to have something like 20–25% of the US population covered under Medicaid, which is a specifically public program, just as one dimension. So we're going to get healthcare being much more of a public sector function than it's been in the past, at least as far as financing goes. Second, I think it's a safe assertion to say that costs have not been addressed by the ACA. And that's something we're going to have to confront again as the system works in, and we will somehow. The necessary measures to control costs, I argue, will involve management challenges similar to Canada's. And why is that? Well, for one thing, since it becomes more public, it's going to become more politically salient, since there will have to be some cranking down of the, I would say considerable cranking down of the payment systems. You're going to have something closer to global budgeting. You do already in Medicaid managed care, for example. And the same kinds of stressors that we see in Canada are going to creep into our own system. Now, we're not going to do what Canada did. We can't legally, we're not going to see seizure of hospitals, which is essentially what happened in most of Canada. We're not going to see a change in the relationship of the states to the federal government because our constitution is different. But we will see a working through of the same issues that work out as stressors, such as the political salience and the need for tight control over budgets. And I would predict that what this is going to do is going to create stressors very similar. Our management profession, healthcare management profession, is going to have to deal with this and run a system. And ultimately, whatever policies we develop are going to be successful or unsuccessful to the degree to which they are, in fact, manageable.
That's it, huh?
That's it.
All right.
Thank you.
Can any system succeed with those conflicting objectives? And I think the answer is no. And I think I would like to follow Robbie Burns of Wharton, who has what's called the iron triangle, which is that in healthcare, and you probably studied this at length, we have this irreducible conflict between prices, right, costs, quality, and service. So I'd add that quality dimension to the dichotomy you had between access and cost. I'd say that the quality leg is another one. And Robbie says you can have any two of those three. But you don't have to have two. You could end up with one or none. And we could go around the world in comparative health system study and sort of think which systems have none of these or only one of those three things. No one has three. And I claim you can't get three. And I appeal to Bubba Gump. Many of you may have been to a Bubba Gump seafood restaurant. You may have seen Forrest Gump the movie. So there's a couple of Bubba Gump restaurants. And they have these little jokes printed on little bits of metal, and they're stuck everywhere in the restaurant. And there's one that says, Bubba Gump is saying, price, quality, service, pick any two in his restaurant. And so I picked quality and service, and I paid a lot more. I didn't economize on price. But this is not a sophisticated problem. It's really, really tough to do all those three things. Like you said, you want more access, you're going to pay more. You want better access and better, more innovative evidence-based medicine, you probably are going to have more quality, but you'll pay more. And so no one's figured out a way to do that. Preventative care was often held to be the thing that if we invested just the right amount of money in preventative care, we're going to nail this iron triangle. Well, it turns out no. This is sort of a fundamental rule of our universe, that we can't have all these things. So I think the first best problem, right, can these people ever solve it? Can any humans ever solve these conflicting policy objectives? I think it's not. And so I think then it becomes really interesting to how these people are living with that, right? And it becomes less an issue of, oh, whoa, these people are not doing the right thing, they're not achieving objectives, because no, that's not possible. How good are they doing second or third best solution to that? And I think you really touch on the stressors that these folks have. And I like how he's figure one, the stressors, and then the conduct, and then the performance. reminds me of when I was a management consultant and we borrowed McKinsey's SCP methodology, you know, the strategy, the structure, conduct, and performance of an industry. I think it's a nice kind of little tool, little framework to have to organize your thoughts. You know, I don't know, some of you mentioned transit. Well, what's the structure of the funding and operation of transit systems? What's the conduct of the players there, private and public, and how do they perform? I think it's a useful little triptych way of approaching these problems, and it helps you organize your thoughts. I think, you know, Howie alluded to some of the soft cultural things, right? And you didn't have time to get into them, but I think Canada is such a special case, right? It's such a European solidaristic place. It's so different to America, even though they look similar and speak similar languages, right? Like, yeah, the fact that you were saying, like, you know, the people liked it as long as it was different to the US, right? That's kind of a cognitive bias, right? That's not really an irrational thing. Like, to really have a utility function where you feel better because you stuck it to the man south of the border, that's an odd way to feel happy, right? I teach a case about a Toronto hospital, and you look at some of their performance outcomes. For example, the provincial goal is you will wait no longer than 180 days for a hip replacement when you're in severe pain and can't walk. They achieve 330 days, and they feel really good because it's down from 370 days the year before. I mean, like, you know, you have to feel pretty good about your healthcare system to live in a system which really essentially rations healthcare and, you know, puts you through enormous pain, and you're waiting there the same as everyone else. It's very egalitarian, very fair, probably very efficient use of the resources, but gee, you know, if you were by accident of birth born on this side of the border, you would have had that operation 3 days after you went to your orthopedic surgeon, you know, because that's a juicy, lucrative procedure to do, very standardized technology. You'll have a great outcome, you'll feel great, no more pain, unless you happen to get a metal on metal hip, which in that case, you know, you'll complain a lot. So I think, you know, this cognitive issue, this cognitive biases, the cultural issue is a really interesting background to your case study. And I wonder, like, if one can sort of stress that management is of that culture, right? The employees are of that culture, the customers are of that culture, the politicians are of that culture. How does that change what you find? I thought that was interesting and maybe worth adding. I think the dichotomy you mentioned between the hospitals getting this envelope of money, you know, directly from the RHA versus the physicians getting paid more from the provincial Ministry of Health level, this raises this huge dichotomy, right? Where you would think, we would like to think south of the border, that a single payer environment allows you to avoid local optima. It allows you to perfectly calibrate the inputs into a healthcare production function amongst hospitals, physicians, physician substitute, pharmaceuticals, long-term care, you know, self-care. But just the way you've described this simple kind of historical axis of one important set of healthcare inputs, hospital care, being locally controlled and locally managed, and the other one being provincially managed, makes it appear to me that you've got this inbuilt kind of failure waiting to happen, right? It must be really hard to make those guys align with each other, just economically, let alone by incentives and operations. The other interesting kind of local optima, global optima thing that came out of the case for me was, you would think if you had an RHA that was controlling multiple hospitals within its authorities' borders, that you would be able to perfectly match the supply of healthcare, right, to the demands of healthcare. And you would think that this would be something that would be kind of, from a kind of perfect manager's point of view or an economist's point of view, really easy to do, right? Because you control all the money, you control the levers of power, so you should be able to do it. But I got a sort of a sense from the stresses you're talking about that in fact it's very political, and you have a lot of grandfathering and special pleading and political relationships. And so I'm wondering, how different is that then to our shoddy system, where we don't have an RHA, but we have all those kind of nasty political issues, and this hospital asks for county money to survive and appeals to the public and the governor. You know, we seem to have similar kind of daily to's and fro's in our political system here, despite, you know, those guys having this additional set of tools and levers. And I wonder if you're able to you know, comment about, are they actually relatively more successful? Is there relatively less infighting? You know, like you observe it, but you know, relative to us, is it worse? Is it better? Well, that might be an interesting tack to take. What else was I here? The global budgeting formula they're going to have the same. I mean, the case I teach about Toronto talks about some of the issues that they have trying to determine the right funding formula. And also in Toronto, you have this desire to not have healthcare grow faster than the kind of the provincial GDP. And it's extremely hard. In this country, just to give you a sense of how hard that is, the gap historically is something like 2 to 3% excess healthcare growth compared to GDP growth. So when you try to keep it right, at the level of GDP growth, you're saying that although you as a country, as a province are getting richer, you're only allowed to spend essentially the same proportion of your income for healthcare. Mm-hmm. And that doesn't seem kind of fundamentally reflecting the reality of consumers, right? Healthcare is one of those things, as you get richer and as you satisfy progressively more of your kind of simpler, things like color TVs, right? At the end of the day, you had a whole pot of money. I don't necessarily need another color TV. I'm gonna die. I would like to live another couple of months. So I want to spend more on healthcare as I get richer. So if you believe in that kind of simplified view of what a healthcare consumer does, you would imagine that as I get richer, I should have a higher share of my GDP devoted to healthcare. And some Stanford guys who are right-wing economists, Hall and Jones, in 2007 have a piece in a peer-reviewed economics journal, where they say that based on their sense of how valuable healthcare is to us as consumers, right, based on empirical data, they feel that the share of GDP devoted to health should be about 30%, as opposed to 17%. So nearly double, and certainly maybe quadruple what it is in Canada. And so it's tough when we say their desire is to control costs. Is that a fiscal aim, or is it really related back to what we think the kind of true, real preference is for how much should be given to healthcare amongst society's value for the goods and services produced, right?
Great question.
So this is another dichotomy. In your case, I guess it should be called, lots of dichotomies. Should be something. You've got all these different contexts there. And I really like the way you bring this to U.S. healthcare, right? So you're doing a case study which is interesting all by itself, but to really make it appeal to publications here, you've sort of set up this nice bunch of straw man questions about which way should we go? Does this reflect that we will succeed, or that we will fail, or that we can't get there? And I think that's really important, that link to ACA. And I really agree with what you said verbally in the last few minutes about we're not going to be able to nationalize hospitals. We have this great law in this country, the Hill-Burton law after the Second World War, that put in probably 30% overcapacity in hospitals. And once you have hospitals out there in the community, it's extremely hard to remove them. Right? Generically, that entitlements, welfare, good things in life, the loss that we feel from losing them is much more than we would actually value than if we didn't have them and were asked how much we were willing to pay for them. I have a pal, he's the CEO of a small hospital in Georgia, in rural Georgia, about an hour from Augusta, out in the boondocks on the way to Atlanta. There is no system I know of in the world that could justify the money that's being spent to keep his hospital there, right? He's got a 50-bed hospital. The society needs a 5-bed ER/low-risk antenatal care place, and it needs a taxi service to Augusta, right? But guess who's sitting on his board? The local mining magnate, the local Walmart CEO, the local car dealership CEOs. Every luminary in that small little city are sitting on his board. You try closing that. I mean, you might as well, make the Communist Party take power in rural Georgia. It's kind of just impossible to imagine. So I like the way you said you thought some of these policy solutions we won't be able to adopt in this country. And so that sort of set up for me this even greater potential stressor for future bureaucrats and scholars who are looking at this, which is how do we deal with all this increased government involvement, and yet we have not even those rudimentary tools that our cousins north of the border have. And so what is that? Does that prejudge our ability to succeed? What's the administrative feasibility if I'm just tinkering with pay for performance and little incentive payments? And so in closing, I think I want to step back, which is, I sound a little bit critical, right? Smug and critical about our cousins north of the border, right? But, that's ethnocentric. And I'm from Australia, so maybe I should be the last person to talk about other cultures, right? We have our own kind of distinct culture. And Australia is very similarly organized to Canada, both politically and organizationally here. Funding-wise, this is almost Australia in my mind. Right? And people are happy down there. That's a political decision they make. If people, like when I was a doctor in Australia, when we had visitors from America come, they'd go on rounds with us, we'd ask them, we'd tease them, what would you do for this patient?
Interesting.
They'd say, I'd invest in all this, I'd do a CT, and we're like, bullshit, you know, we'd do a $75 blood test, that'll tell us the answer, we don't want to know anything more. You're going to do a $700 CT scan, totally unnecessary, blah, blah, blah. We'd laugh at them. But that was us being ethnocentric towards the US model. You know, I think you'll know this better than me. Countries deserve the governments that they elect. These are political choices that are made. I want to be very careful that I don't come across criticizing the Canadians. That's their approach. They're very proud of it. The smugness I have towards the Canadians comes across because they're free riding on the US taxpayers. Right? Canada doesn't have a thriving biopharmaceutical industry, so Canada has no problem negotiating extortionate marginal cost prices for its biopharmaceuticals that it gets from US firms, as Europe does, right? So you're starting off with 10% of your healthcare budget is zero because you're basically stealing at a marginal cost from firms whose R&D costs are being paid for by us as taxpayers, right? And you know, they're doing a lot of kind of sneaky stuff about their physicians. 25% of, certainly the province of Ontario, 25% of the medical graduates are foreign medical graduates. So they're dealing with a lot of things by kind of substituting cheaper inputs, less politically powerful inputs from outside the country, bringing them in and having them work there delivering care. So they're doing a lot of kind of sneaky stuff, and that's my snugness. But at the end of the day, it's a great country, and I don't want to be criticizing them too much. I think we should have to get our system right first and appeal to smugness. How do you think it's—
Well, I appreciate your comments. I just want to make one response, and that is the willingness of people to wait for procedures. And so, for example, my chairman up at UBC was waiting, had been waiting for a year to get a hip replacement. He couldn't stand. He couldn't stand up for any length of time. Another gentleman I met out at the campus in Paloma, up in the England area, he needed 2 hip replacements and 1 knee replacement. He really was hobbling around. And all these guys at my age, so I can relate to it. And my surmise is that nobody complained. They weren't trashing the system. They were going to wait around and live with it, and you know, they knew what the issues were. But you know, I think that to some extent, acceptance of pain is a socially cohesive phenomenon. You know, we're tough.
live in Canada. It's really cold there.
Yeah, we don't live in Santa Barbara. We live in Prince George, and we can take it, and you can't. And isn't that great? So that's just to add a bit of a sociological input.
You remember Maggie Thatcher, the former Prime Minister of the UK? She said, you know, socialism is an equal share of nothing, and capitalism is an unequal share of a lot. You know, and I think if you kind of calibrate that a bit, it's kind of in Canada, right? It's an equal share of a lot less, and us here in this country, we have a totally unequal share of a lot more. You know, and so depending on how you orient it to fairness and tolerance for pain.
Interesting. Thank you.